Asthma is a chronic inflammatory disorder of airways that causes recurrent episodes of wheezing, shortness of breath, chest tightness, and cough. This mainly happens at night and early morning. The hallmarks of asthma are airway obstruction that is intermittent and reversible, so it's not continuous and not permanent. Chronic bronchial inflammation with characteristic eosinophilic infiltrate, bronchial smooth muscle cell hypertrophy and hyperreactivity, and increased mucus secretion. The major factors contributing to the development of asthma include genetic predisposition to type 1 hypersensitivity, acute and chronic airway inflammation, bronchial hyperresponsiveness to a variety of stimuli. Asthma can be triggered by the exposure to different stimuli, topped by respiratory infections, mainly the viral ones, airborne irritants like smoke and fumes, cold air, stress, and exercise. This figure shows the initial airway response after exposure to one of the inhaled allergen for the first time. The allergen or the antigen will be recognized by antigen-presenting cells or dendritic cells in the epithelial lining. As a result, T helper lymphocytes will be activated and start releasing inflammatory mediators, resulting in IgE production and eosinophils activation and recruitment. Interleukin 4 and interleukin 13, for example, stimulate the IgE production. Interleukin 5 activates the eosinophils, and interleukin 13 stimulate the mucus production. IgE coats the submucosal mast cells. Upon the re-exposure of the mast cells to the same allergen or antigen, two waves of reaction happen. One is the early or immediate phase and the other is the late phase. The early phase reaction is dominated by bronchoconstriction, increased mucus production, and vasodilation. Bronchoconstriction is triggered by mediators released from mast cells, including histamine, prostaglandin D2, leukotrienes, for example, leukotriene C4, D4, and E4, and also by the reflex neural pathways. This figure highlights the early phase reaction, so it happens after re-exposure to an antigen. This reaction is triggered by antigen-induced cross-linking of IgE that is already bound to the Fc receptors on mast cells. Mast cells released a previously performed mediators that will induce bronchospasm, increase vascular permeability, mucus production, and recruitment of leukocytes. The late phase reaction is inflammatory in nature. Inflammatory mediators stimulate epithelial cells to produce chemokines, including the eotaxin, which is a potent chemoattractant and activator for eosinophils. This results in recruitment of T helper type 2 lymphocytes, eosinophils, and other leukocytes, and also amplifying the inflammatory reaction. As I mentioned in the previous slide, the late phase reaction is inflammatory in nature. Leukocytes recruited to the site of reaction, including neutrophils, eosinophils, basophils, lymphocytes, and monocytes, initiate the late phase reaction. Eosinophils release the major basic protein and eosinophil cationic protein that cause damage to the epithelium. Repeated bouts of inflammation will lead to structural change in the bronchial wall. This is called the airway remodeling, which includes hypertrophy of the bronchial smooth muscle, hypertrophy of the mucous gland, increased vascularity, and deposition of subepithelial collagen. This figure shows a comparison of normal airway to the left and an airway involved by asthma to the right. As you can appreciate in the right figure, there is a green layer of mucus overlying the surface epithelium. Asthmatic airways marked by accumulation of mucus in the bronchial lumen. Usually this happens secondary to the increased number of the mucus-secreting goblet cells in the mucosa and hypertrophy of the submucosal glands. The mucosa here is seen just below this thick layer of mucus and shows frequent mucus-secreting goblet cells. Then you can appreciate the thickened basement membrane beneath the epithelium, with intense chronic inflammation composed of eosinophils, macrophages, and other inflammatory cells. Smooth muscles hypertrophy and hyperplasia, along with hypertrophy of submucosal glands, can be appreciated too. So the airways in patients with asthma show the following: increased number of mucus-secreting goblet cells, hypertrophy of submucosal glands, accumulation of mucus in the bronchial lumen, thickened basement membrane, intense chronic inflammation, and hypertrophy and hyperplasia of smooth muscle cells. The first and the most common type of asthma is atopic asthma. It's considered as a classic example of type 1 IgE-mediated hypersensitivity reaction. It usually begins in childhood. A positive family history of atopy and asthma is common. The onset of asthmatic attacks usually preceded by allergic rhinitis, urticaria, or eczema. Attacks may be triggered by allergen in dust, pollens, animal dander, which is the material shed from the animal feather, food, and/or infections. As we mentioned in the previous slides, the initial exposure to an antigen will result in excessive activation of type 2 helper cells that will start releasing cytokines, of which are interleukin-4 and interleukin-13, that starts stimulating the IgE production, interleukin-5 activating the eosinophils, interleukin-13 that stimulates the mucus production. Then IgE coats the submucosal mast cells. Upon re-exposure, the release of the mast cell-derived mediators happen, and this will produce two waves of reaction. The first is the early immediate phase of reaction, and the second is the late phase of reaction. A skin test with a causing agent results in an immediate wheel and flow reaction. The skin prick test, for example, is the most common allergy skin test. So what we do? First, we get a series of tiny drops of the allergen on your back. Then you get a quick needle prick in the skin underneath each drop. If you are allergic, you will get red and itchy rash, especially at the needle prick site. Atopic asthma can be also diagnosed based on the serum radioallergosorbent tests, which is a blood test using radioimmunoassay to detect specific IgE antibodies and then to determine the substances a subject is allergic to. The second type is non-atopic asthma. Here the patient do not have evidence of allergen sensitization, so the skin test is negative. A positive family history of asthma is considered less common in this type. Respiratory infections due to viruses such as rhinovirus and parainfluenza virus and inhaled air pollutants such as the sulfur dioxide, ozone, nitrogen dioxide are common triggers. Although the connections between those exposures and the non-atopic asthma are not well understood, the ultimate humoral and cellular mediators of airway obstruction are the same to both atopic and non-atopic variants of asthma, so they are treated in a similar way. The third type is drug-induced asthma. Several drugs can provoke asthmatic attacks. However, aspirin is considered the most striking example. Patients with aspirin sensitivity present with recurrent rhinitis, nasal polyps, urticaria, and sometimes bronchospasm. The precise pathogenesis is unknown, but it's likely to involve some abnormality in prostaglandin metabolism from the inhibition of cyclooxygenase by aspirin. This type of asthma can be triggered by fumes, dusts, animal substance, chemicals, and gases. This happens after repeated exposures to the causing agent. Examples include farmers, animal handlers, manufacturers of foam mattresses, bakers, food processors, cotton workers, manufacturers of metals. The most striking finding in asthmatic patients is the occlusion of bronchi and bronchioles by the thick mucus plugs. These mucus plugs contain walls of shed epithelium and called Kirschmann spirals. This figure represents a bronchial biopsy from an asthmatic patient showing the following. Subbasement membrane fibrosis, marked by the yellow star. Eosinophilic inflammation, marked by the red star. And smooth muscle hypertrophy and hyperplasia, marked by the green arrow. Eosinophils are the characteristic inflammatory cells in asthma. Charcot-Leyden crystals are another finding and represent crystalloids made up of the eosinophilic protein galactin-10. The characteristic morphologic changes in asthma are called airway remodeling, which includes thickening of the airway wall, subbasement membrane fibrosis, increased submucosal vascularity, an increase in the size of submucosal glands and goblet cells, metaplasia of the airway epithelium, and hypertrophy and/or hyperplasia of the bronchial muscles. In severe advanced cases, the lungs are distended due to the air trapping with small areas of atelectasis. This figure shows a predominantly expanded submucosa. As you can appreciate, the submucosa lies between the bronchial cartilage on the right, which is marked by the red star, and the bronchial lumen that is stuffed and filled with mucus and marked by the yellow arrowhead on the left. The submucosa is widened by smooth muscle hypertrophy, edema, and inflammatory cells, mainly eosinophils. An attack of asthma is characterized by the following: cough, which is often worse at night or early morning; wheezing, which is a whistling sound, especially during expiration. Sometimes this sound can be heard easily even without the stethoscope; chest tightness, as the patient may feel something is squeezing or sitting on their chest; dyspnea or shortness of breath. It's like you can't catch your breath or breathe deeply enough. Asthma usually is associated with difficulty in expiration. Each asthmatic attack may last from 1 to several hours and subsides either spontaneously or with therapy. The intervals between the attacks are free from the respiratory difficulties. Remember, asthma is reversible except in advanced severe cases. Status asthmaticus is a severe paroxysm that does not respond to therapy. This type of attacks persists for days or weeks and may be associated with hypercapnia, acidosis, and severe hypoxia. In some patients, this is fatal. The standard therapies include anti-inflammatory drugs such as the glucocorticoids and bronchodilators such as the beta-adrenergic drugs and leukotriene inhibitors. As you may recall, leukotriene inhibitors are potent bronchoconstrictors. However, those agents can block specific immune mediators such as interleukin 4 and interleukin 5. This effect can be helpful in some patients. Bronchiectasis is defined as permanent dilation of bronchi and bronchioles. This is caused by destruction of smooth muscles and the supporting elastic tissue. So it's an irreversible dilation. Remember, permanent. But this time it affects mainly the bronchi and the bronchioles. You can compare that with what happens in emphysema, which is defined as permanent dilation of the airways distal to the terminal bronchioles. The destruction of smooth muscles and elastic tissue here typically is associated with necrotizing infections. So this disorder is not a primary disorder. Instead, this disorder is always related to a primary process such as persistent infection or obstruction. Bronchiectasis is defined as permanent dilation of bronchi and bronchioles. This is caused by destruction of smooth muscles and the supporting elastic tissue. So it's an irreversible dilation. Remember, permanent. But this time it affects mainly the bronchi and the bronchioles. You can compare that with what happens in emphysema, which is defined as permanent dilation of the airways distal to the terminal bronchioles. The destruction of smooth muscles and elastic tissue here typically is associated with necrotizing infections. So this disorder is not a primary disorder. Instead, this disorder is always related to a primary process such as persistent infection or obstruction. Clinically, the characteristic symptom complex is dominated by cough and expectoration of copious amounts of purulent sputum. Purulent sputum usually contains white blood cells, cellular debris, dead tissue, and mucus. Purulent sputum is typically yellow or green in color and can be seen in cases of bronchiectasis and lung abscess. The diagnosis of bronchiectasis depends on an appropriate history and radiographic demonstration of the bronchial dilation. The development of bronchiectasis is based on two intertwined processes. The first is obstruction and the second is a chronic infection. Obstruction that is caused by foreign body, for example, impairs the clearance of secretions. So the secretions starts to accumulate, providing a favorable media for superimposed infection. So the secretions and the bronchial wall are infected now, and this induces an inflammatory reaction. The inflammation will result in tissue damage, especially to the bronchial wall, and also accumulation of exudate, which will further distend the airways, leading to irreversible dilation. Conversely, a persistent necrotizing infection in the bronchi or bronchioles may lead to poor clearance of the secretions. This is followed usually by obstruction due to the accumulation of secretions and inflammation with the bronchial wall damage resulting again in full-blown bronchiectasis. As we learned, it's a secondary process that happens due to another primary disorder. The most common primary disorders include the disorders that causes bronchial obstruction, congenital or hereditary conditions, and necrotizing or suppurative pneumonia. Let's start with bronchial obstruction. Bronchial obstruction can be caused by tumors, foreign bodies, and impaction of a mucus, for example. In these conditions, bronchiectasis is localized to the obstructed lung segment. Atopic asthma and chronic bronchitis can also cause obstruction and bronchiectasis. Congenital or hereditary conditions as in cystic fibrosis. In cystic fibrosis, there will be a widespread severe bronchiectasis. This results from the obstruction caused by abnormal viscid mucus and secondary infections. Remember, cystic fibrosis is a hereditary disease that affects the lungs and the digestive system. The body in this disease produces thick and sticky mucus that may block the lungs and obstruct the pancreas. Immunodeficiency states is another example, in which a localized or diffuse bronchiectasis develops because of the recurrent bacterial infections. Primary ciliary dyskinesia, which is also called the immotile cilia syndrome. It's a rare autosomal recessive disorder and is associated with bronchiectasis and sterility in males. It's caused by inherited abnormality of the cilia. This type of abnormality impairs the mucociliary clearance of the airways, leading to persistent infections. Necrotizing or suppurative pneumonia, particularly the ones that are caused by the virulent organisms such as the Staphylococcus aureus or Klebsiella species. Macroscopically, bronchiectasis usually affects the lower lobes bilaterally, particularly the vertical air passages. Usually, the most severe involvement is found in the more distal bronchi and bronchioles. The airways may be dilated as much as 4 times of their usual diameter. This figure shows the gross appearance of a lung that is involved by bronchiectasis in a patient with cystic fibrosis who underwent lung resection for transplantation. As you can appreciate, the cut surface of the lung shows marked dilation of the bronchi, and those bronchi are stuffed and filled with purulent mucus. The histologic findings vary with the activity and the chronicity of the disease. In full-blown active cases, the main histologic findings are an intense acute and chronic inflammatory exudate within the walls of bronchi and bronchioles, desquamation of the lining epithelium and ulceration, and this happens due to the severe inflammation. Typically, mixed flora can be cultured from the sputum. The usual organisms include Staphylococcus, Streptococcus, Pneumococcus, enteric organisms, and anaerobic bacteria. When healing occurs, the lining epithelium may regenerate completely. However, the injury usually cannot be repaired completely and abnormal dilation and scarring persist. Chronic cases may have fibrosis of the bronchial and bronchiolar walls and peribronchiolar fibrosis. In some cases, the necrosis destroyed the bronchial and bronchiolar walls, producing an abscess cavity. This figure shows the histologic findings in bronchiectasis. As you can appreciate, at the center of this figure there is an extensive necrotizing inflammation to the degree that you cannot appreciate the mucosal lining. Mostly it's desquamated. Clinically, bronchiectasis is characterized by severe persistent cough associated with expectoration of a mucopurulent sputum. Other common symptoms include shortness of breath or dyspnea, rhinosinusitis, and hemoptysis. Symptoms often are episodic and induced by, for example, upper respiratory tract infections. Severe widespread bronchiectasis may lead to significant obstructive ventilatory defects. This can be associated with hypoxemia, hypercapnia, pulmonary hypertension, and cor pulmonale. However, with current treatment, outcomes have been improved, and severe complications of a bronchiectasis such as brain abscesses or the cor pulmonale are less frequent.